that brings us on to the next speaker, Eva Lee, who's also been doing a whole lot of hands-on simulation and modeling work. And yeah, Eva comes originally from an operations research background, very actually similar to my own background. Way back, my PhD was in numerical analysis, which had a whole lot of operation research applications, and has done a bunch of work on the optimization theory and practice and systems biology operations in healthcare, but also a whole lot of practical work applying optimization and modeling techniques to public health. So working with the CDC on defense against bioweapons. I mean, she was in Japan helping to develop rapid responses to the Fukushima disaster, and has worked on the optimizing influenza vaccines also. And among many other things, for a long time now, has been working on software called RealOpt, which does detailed modeling for strategic planning and for sort of practical operational responses to pandemics, outbreaks, all sorts of other disasters. And this really integrates, it's sort of the opposite spectrum from the simple qualitative models we've been looking at here. This RealOpt really integrates all sorts of different data from all different government information systems to try to form highly accurate models of real world situations. So I think, yeah, it's fantastic that Eva has agreed to share some of her experience here with us, which I think is highly relevant to the detailed, in-depth modeling of COVID-19. So yeah, with that, oh, I should also add, Eva was trained in Hong Kong partly, which is where I've been for the last 8 years. And you know, Hong Kong has done an amazing job at addressing the pandemic. I mean, being now in US, having been in Hong Kong like 6 weeks ago, there's really no comparison. So there should be a lot of valuable knowledge coming out of Hong Kong in general for dealing with this pandemic. So yeah, thanks, Eva. Let's get started.
Thank you. So let me share my screen. Can you hear me?
Hear you just fine.
Good. So, and you can see my screen, right? Great. Okay. And so yeah, thank you for the invitation. And I thought, I guess maybe it's Ben that put together the schedule. That's perfect. I really love the high level talk, and I love the every single speakers that have spoken before me, because you said everything in perfect condition. Like, so I don't have to go into detail of the mathematics, but it is also like now everybody is aware of how complex the problem is. So I want to share with you some of the like what we have done with the government and the policy, like how it is being implemented. And so a lot of my work, as Ben mentioned, is really related to emergency response and related to chemical, biological, radiological disasters. Of course, pandemic is part of it. And I serve on the National Preparedness and Response Science Board, and basically trying to really come up with strategies to protect the citizen. And in a sense, a lot of times we really think about pandemic flu, and clearly pandemic flu, we have vaccines, right? At least we have a chance of like being able to dispense vaccination and doing all those. But in this case, we don't really have that. And so a lot of the work then is like, how do we actually handle all of these, both within the United States as well as in other countries? And I think it's interesting. I know Hong Kong is doing really well, but I can't say I really know much about what they do, except that I've learned a lot for the last 2 months, and I'm grateful, like some of the experience that they have and they were able to share with us. So RealOpt is a pretty complex system, and it has the agent-based. So let me see if I could use my cursor. So it has the agent-based simulation, and basically you basically would just input any maps of any form, of any location, and you can actually simulate, and it's actually quite neat. And we got like this is for biological attack, and some of it is for radiological. CRC is for radiological, and you basically could accept census data, demographics. You can accept citizens data, on the ground information, and GIS information, and all of these in real time. And then we were using that in real time to respond to the Haiti operations. And I was in Japan. And I think the challenge with us in Japan is that we couldn't speak the language. And we get some really good information, but none of us could understand it. So it was an interesting experience, but nonetheless, it was very effective. So the idea is really this system has 12 different modules, some of which is just a deploying to emergency responders, and they use it right on the ground. Others is they log in and basically provide a lot of information, and then central commanders will be able to respond. So I just quickly go through that, just only 2 slides on the mathematics, since many of you are experts in mathematics. So I don't want to mention that too long, but some of it is, I really like the emphasis on optimization. I think simulation and agent-based absolutely is critical, because you can make it really dive into the micro level, but you can also look at the macro level. So basically you can control a single agent, an individual, or a family, a group of people, a business, small business, big business, in many different levels of granularity that truly gives you a lot of power. But of course, we always know the key issue is, or the challenge itself is that it is really computationally intensive. And that's why all of us are here, because I guess we are the nerds that love to deal with very challenging problem. But behind the simulation itself comes the powerful thing is that you can optimize. And that's important, is that the work always involves is that I want to optimize the scenario on the ground, but I also want to make sure we can optimize the scarce resources. Now, it's one thing to say, well, if you're in Africa, you don't have enough resources. But those of us that are in the United States, you know really well that we don't have enough resources to deal with the COVID-19, because so many patients require really intensive hospitalization. So the back end itself has a lot of the simulation part on disease propagation, knowledge spread. So during disasters, it's not just you have to deal with really the disease spread or everything. You have to deal with also a lot of noise in the background, a lot of citizens like hearing many different type of ideas. What can they learn from it, or who should they really listen to, right? So that's like, if you're in the United States, you understand it is really confusing to hear the governor say one thing, the mayor say another thing, the president said another thing. And then all of a sudden, every one of us asks, okay, what exactly is going on? Like, it's like, are we in a position where we are ready to open up, or we are not? So then at the end of the day, the numbers on the ground is going to be the truth that to tell us what's going on. So in the design itself, very early on, I have to thank the doctors, because the system is designed for users that have to be able to use it. And look, we have all the mathematics and we got all the computational power. If they don't know how to use it, it does not help. So I like to be able to make the system so that people actually could design the layout of their sites and what the process is, and what type of disease they want to look at. And then in the back end, all the mathematics and computation kicks in. You basically can actually monitor this and run this yourself, and you don't need an expert to teach you. And I think that turns out to be extraordinarily important. And the doctors and public health are really, they are really expert in learning that. So now let's go to COVID-19. So lay out the background of the computational side. And so what do we know about COVID-19? So it is very contagious. In fact, it is infectious during the last stage of incubation. We have asymptomatic and symptomatic patients. Also, there is the infectious patients remain infectious after they recover. And so they continue to share the RNA. And so that is problematic. Not talking about whether the patient themselves is immune or not. You're talking about just they remain infectious. And that is very, very difficult to handle. And their potential transmission through fecal matters. And it's unusual long incubation. Some people would stay, would just be like 2 days of incubation or 1 day incubation, and they have onset of disease. but others may last for 21 days incubation. So it becomes really difficult to track individuals. And it seems to attack older adults and with existing condition, but that is not the case really. If you look at statistics, like in Georgia, 65% of the people that are infected are between the age of 25 to 50. So then you think, now this is very bad, right? The young and the healthy. So the young and the healthy actually get infected, and that it actually attack the heart, not just the lungs. It actually have multiple mini strokes on patients, and at the end they died from heart attack. So in close environment, what we notice is that the attack rate is the same across the young or the aged. It's about 10 to 30 times more deadly than seasonal influenza. And that is the first estimate that I have. And I might actually revised it recently because of some of the data that I got. It's highly contagious, and the DNA already, like the genomic matter of the virus already mutated in Wuhan. And I won't be surprised it has already been mutated in the United States, because there are reports already supporting that. There are transmission to the dogs. In Hong Kong, I think there were 2. In the United States, there's 1, and there are 4 tigers infected, and there are 3 cats, I think, infected also in the United States. So you're thinking about really a whole lot of stuff going on, and it's, in a sense, we are never ready for such type of pandemic. It's a lot broader than we thought. So if you look at the transmission itself, now I really love the way, like a lot of you talk about social distancing. So we talk about like, we could have like our coworkers, sorry, a lot of noise here. And that's the acquaintance and their close relatives. And then there are passerby that just walk by, and you may infect someone because it is so highly contagious. And then you talk about healthcare workers. So very surprising, in New York cities, almost 60% of the healthcare workers were affected. Okay, so affected. So not all of them have symptoms, but nonetheless, this is amazing, highly contagious, because these healthcare workers are not like walking around with no protection. These are like healthcare workers in proper PPE. They are also not those that have no proper PPE and have face shields, face masks, and everything. And they are infected too. So you're looking at that, and I want to give you an idea. So in one of the study of a COVID-19 patient, and when we actually went to the house, 70% of the environment were contaminated with the RNA. So you can see it is very, very contagious. So this is the disease tree we look at, right? We have one individual at the root node, started with time 0. And then this is how it spread, about 2 to 3 people that per individual. So how do we contain? And I think we are beyond containment in the United States, but in some other countries, they are starting. So we are helping too. So I guess I'm helping with some of the other countries. So case isolation is that if we can catch the individual by doing testing, then we can prune the disease nodes rapidly. Or if we are too late, then we divide and conquer. And that is what they're disturbing the social networks by splitting them as small as possible, so that the connectivity is disturbed and they cannot spread. Now, it is not true they cannot spread. It is just that they cannot spread in such a large degree and that you can control them. So if you look at this one, to give you an idea, like if we prune this little node, and if we case isolated, that means we tested and we were able to catch this individual early enough, then we have pruned this one and there will be no infection here. So there will be no exponential growth here. That requires rapid testing. And you can do drive-through, you can do, you can leverage technology, definitely. But there's a lot of bottleneck here with drive-through. And this morning I was just with my local jurisdiction, and they had a drive-through, and they have to do scheduling on those individuals coming in. And it took 5 days for the test to come back. Shocking, because it shouldn't be like this, because this is the end of April. And I expect, in fact, I told them they will expect half a day in January, back at the end of January. But now it's the end of April, and they told me it took 5 days. I said, okay, I'm not so sure exactly what's going on. So we have to dive down right into the testing part. Then case isolation, the next step then is divide and conquer. That's like school closure or telework, and try to decentralize this so that you are able to break them down into small pockets. And that means you know that there could be infection, but they are small enough for you to be able to contain them and to treat them. And that's important. And I love the comments about like you don't want to send people home to quarantine because there is really no such thing called you are able to isolate, even in the United States, of course. Then you think about in other countries where the living quarters is a lot smaller. So what has been done is very effectively, I learned from Hong Kong, is they isolate them in some of those new public estate, and now they are running out of those space. And basically isolation is a must, because if you expect people to be able to quarantine at home, then they basically, the whole family is infected and some could die, and that's not good. How to test and how much do we have to do and how fast do we have to do? And so I think like Diamond Princess gave us a very good study, a good study of what not to do. And I think that's like the one that we observed it so closely starting the first week of February. And it started January 20th. An individual has no symptoms, basically enter, like get on board of the ship, and that disembarked on January 25th to Hong Kong, if I remember it correctly, and 6 days later was tested positive. But if you look at the amount of people that this individual has infected, it is humanly not possible if this is the index case. So it is a very odd thing, but it is also odd is that it shows the whole concept of testing in the right way, you can avoid the spread, and testing in the wrong way, you basically get the maximum amount of exposure to everyone. And so what they were doing is testing just those with symptoms and pulling them out, and then basically unable to disembark all the people, unwilling to disembark all the people. So I want to show you. So I tested it. It is about just use the first 3 days of the data about how fast they grow. And so I was able to figure out it's about 3.0, the R0, which makes sense because of the environment that's so close. But this is what is disturbing. This is the prediction of infection over the period of 60 days, and it's about 1,000. And right now the total is about 800. And not counting the crew that was being sent back to the ocean, the 1,400 crew members. And it's actually turned out to be quite accurate, is that about 200 to 300 of them is asymptomatic. And so the model gives you a pretty good idea. But if you look at what is interesting, this is what they did. This is what they could have done if they do strategic tests. It would have lowered the infection to about 300 people only. And mortality will reduce by just to 3 or 4 people instead of like about 9. It's about 12 and individuals. So I think that really tells you why strategic test is so important. And of course, totally opposite of what the policymakers say, that we are going to focus on the vulnerable population, because WHO is spreading the not vulnerable population, right? So that's it. They are the one that spread around the disease. So it's really important. And I think that's really the first understanding is first week of February. We advise the policymakers it's very important to be able to do strategic tests, and that not just focus on the people with symptoms, but really spread it out and do sampling. But those of you that are in United States, you realize that we have the testing problem, and we are unable to overcome that. So I think at that time, strategic test was not possible because we had no testing kits. So this is also a recommendation that I will provide it on how do we actually do contact tracing and also do testing. So again, I do believe that we have exposure to the virus early on in January. I don't think the disease, like the first case was January 21st. And I believe that we have it a lot earlier than that, because when Wuhan actually shut down, like by January 23rd, it really gave me a very clear idea that something went terribly wrong. Not so much about the government, is that the disease itself is so not like understood. So that the government is willing to shut down the entire city to contain the disease. Not so much about to contain the news, which of course we like to feel that way because we know nothing about China. And I was angry at them because I thought, well, I want to know more, but nobody wants to talk to us. But on the other hand, truly, if they do not shut down the country, and they kept it locked down for 76 days, and that is a long, long time. So there's a lot of lessons for us to learn based on their action. And so my feeling is that I need us to test early and to be able to preempt. But that's our training, and we have been trained for so many years that nothing will work if we don't start early, right? So that's the idea. So I also did an early study, and as you notice, this is a very early, because you see very few people were in critical condition in Wuhan, right? So you only have 16,000 cases at that time, very few deaths. So I wasn't really able to get a lot of things. But what we do notice is that on the ground it's about 4% deaths, and it's very consistent even for Italy for the longest time, for Lombardy, and even for Spain, until of course they ran out of the ventilators and they ran out of all the healthcare resources, and then the death toll started to raise even a lot higher. So, but one thing we understand very well, there's no doubt, this is not just a very bad flu, because this is about a disease where lots of people die within a very short time. And so I think this is important. Although policymakers may deny that and feel like, okay, whatever the virus is, they don't know. But nonetheless, I think the deaths, how fast, like 50,000 people died, right? In the United States, close to 60,000 within a month. So this is something we must understand. So and I really like everything that mentioned about how do we do the contact tracing, how do we do treating. So then I want you to know is that one of the things that I do is, in addition to really looking at how do we track these individuals to stop the spread, I already worried about beds and equipment and everything, because look, we will never have enough. That's never have enough. Because if you look at what China has, China pumped in 42,000 medical personnel into Wuhan alone. And they have like 70,000 beds. So I challenged the policymakers, okay, tell me, how many beds could you give me? How many beds? Don't even say 70,000. Just give me 100. I would be happy to start with that, right? So we never have enough of those. So I think, so we quickly really looking at ramping up the personnel. So basically, this is one of the information that I provide to the local jurisdictions and also the states, is how do you recruit the personnel? And they were able to get these people remarkably well. So they were able to recruit all the individuals, although we never have enough, but they were able to recruit it across the whole United States. And that I'm very grateful for some of the experience, like in Asia and also in Italy, the doctors actually sent us emails about the grave situations in Italy, and everything was running out. So I was really happy that they actually gave us warnings on that. So then here I mentioned about how do we reamp the whole process of medical care. So I won't go into detail, it's a really dense slides, but just mention about like, how do you deal with regular patients? How do you deal with COVID-19 zone, that I separate them? I basically want everyone to separate patients, given that patients in the hospitals are vulnerable, and that means they could be infected. And we really heavily lean on to the concept of lean operations, basically using medical field hospitals and mass, like separating patients with different coding and different staging so that you can treat them appropriately, and of course utilizing telehealth. And if there's really any good things coming out of this pandemic, the very first thing I think is that I think telehealth finally took off in the United States. So for those of you that live in the United States, you know telehealth has been in the making for the last 30 years, never took off because there were so many regulations and licensing issues. Doctors cannot treat patients out of their jurisdictions and everything. So we overcame every one of them. So I think that's good, because we need that. And that's the design of the care operations, the stadium. And we had some of these designed when Katrina happened, and also during the Haiti operations. I helped with setting up some of those field hospitals. And so we have those, and so people are understanding what's going on and they adapt to it. So that was also very good. They actually started this before the Pentagon started. And I think Polygon did, of course, they could start a lot faster in terms of the whole setup, but the local was able to identify the sites and getting all the necessary people on board. So the identify personnel, identify utilization, which amazing, hospitals do not know what their utilization is. And understanding the surge. And to give you an idea, I think the first day, the increase in the hospital inpatient is 15%, second day 50%, the third day 100%, fourth day 200%. By the end of the first week, 400%. And then it stayed at exactly 600% for 2 to 3 weeks. Okay, no change. And huge amount. And I also find it amazing about the Chinese data versus what we see on the ground. 20% of the patients need like ventilators. In fact, almost 30% now, and 37% of them. So it's an interesting part. It's very consistent. So I want to share with you some of the results that we get. And instead of saying like how we model it and focus on the mathematics, I want to share with you is what we have modeled in February, and then what we provided to the people on the ground, and of course with a lot of fighting. And I guess not because policymakers are so hard to work with, is that like it's unclear who is in charge. So there's the local commander-in-chief of COVID-19, there's the governor, there's the mayor, there's the president, and there's everyone else. And nobody seemed to really agree with each other. And so I believe that that is really a true challenge. And our results were being distributed to every one of them. And then let them debate. Of course, they all debate, and then they come back to me, and then they argue more, and then they debate more. So I want to share with you exactly what happened to some of the school closure and business closure. So very interesting. I share with you Microsoft, the research director, Eric Horwitz. I believe it's the last week of February, the weekend. So we talk on the phone, and I share with him the school closure result for King County and for Santa Clara. And basically at that time, we already provided to the governor as well as the mayor how to close schools and what to do. And Eric said, well, we have 3 conferences, and one has 500 people and all of them are leadership conferences. One is 500 people, the other is 800, and then one is very large, about 3,000 people, all on the Microsoft campus. And he said, should we proceed? And so he's idea is that he wants to know, is it really serious enough that he should abandon the conference? And understanding is a lot of disruption to the leaders, because all of these are leaders across the whole country and also across the world. So, and my advice to him, yes, absolutely, he has to close. There is absolutely no conference, and no conference. And thank goodness they actually listen. In fact, they also start telework. And so Microsoft turned out to be the fastest one and the earliest one. Then you listen to Biogen conference in Boston, and how it spread to many states, right? And so you understand that's exactly the same time frame. And I'm grateful that some of the leaders were able to act, and it truly disrupt, I understand, but nonetheless, it truly saved lives. And I believe it slowed down some of those community infection. So I think all the speakers gave a beautiful discussion about the model, and I won't spend too much time. So as I mentioned, I have multiple models. So this one is 8 stage, like it has the agent base coupled with the ODE, and then coupled with the optimization on resources, and then coupled with the optimization in minimizing the total infection as well as mortality. So it is a complex system. Nonetheless, it works really well. And I think all of you are experts in this area. You have your favorite models. And I believe that you can absolutely take advantage of all your skills, because I think everything helps. So then what I do is I coupled it with the agent-based modeling and all the optimization, understanding we never have enough resources. And make no mistakes, if United States do not have resources, the next phase that we are going to face in Africa, in South Africa, one of my colleagues now working there, and I have worked with them on MERS and avian flu, those resources does not even exist. I mean, we fight very hard on everything, and everybody fights very hard too. And I think that's why our skills no matter what, big or small, is going to make a huge difference to every single community out there. I think they really need us. And that's why I think it's good. It's like in terms of like every one of us could help. And so this, I want to show you the results. And so my model is a little different than all the other models, is that I really look down into cities and jurisdictions as well as counties, because that is where the actions are, and that's where everything about the data matters a great deal. And I cannot build a single model for United States of America. I simply cannot. But I did run the model for Hong Kong, which surprisingly, it's beautiful, the results, and it really described Hong Kong very well. But if you look at Hong Kong, it's like a little city in the United States. Oh, okay, a big city in the United States. So I think it's pretty good. So this is San Diego, and basically I use all the information and down to the labor information, and it's just all open source information, and I model it, and in a way that it is not microscopic, because I don't want it to be too microscopic. I want it to be general enough so that the answers and the results could be used by policymakers. Policymakers cannot really look at the detail, but they want a big picture out of like everything. So then what I did is, as I mentioned, these graphs were generated in February, and I just plot last week. This weekend, I spent all weekend trying to plot all the confirmed infection and reported deaths onto the graphs I have generated, and figuring out what is the overall effects of non-pharmaceutical intervention, given that we have no definitive treatment, we have no vaccine. So how does it help? And as much as we like to fight like crazy, we can't, because somebody needs to take actions, and they have to take actions. So here is that school closure as I actually envision March 3rd. If it is March 3rd, then this is the type of things that you're going to see. This is beautiful. They closed school on the 16th. Now, do not believe in infection rate here, these little red dots, because a lot of the asymptomatic people were never tested. Even those with symptoms were not tested, because we have very limited resources on testing. But the mortality is beautiful. What you see is that there is a clear changes. Let me see how I could adjust it. There's a clear change in here in the mortality. You can see like it's really follow the graph. It looks so good that I was saying, my good gracious, yes, we're going to lock everyone down, but we don't lock everyone down, because these models assume that some business still open, and they do open. And so I think it is a good understanding of what can be open and how do we keep it open in a way that is safe for everyone. And this is like, so this is San Diego, like just the closing on the, and then this is Hong Kong. So what I did is that I did it for, I think in the first wave, I submitted the results for about 10 cities, the last week of February. And then that create an avalanche of dialogue among the politicians, the governor, senators, and mayor, and just about every single leaders. And then I decided, wow, okay, they are talking. So I want to know, are there any evidence that it actually works? Now, Hong Kong is a strange place, because Hong Kong doesn't have a mandatory requirement of face mask, but 95% of the people wear face mask. So they don't penalize people and fine them if they violate anything, which is different than Singapore. So here is Hong Kong for 2 months. So they started the closure of schools and telework. And they don't also require telework. They basically government telework, and then all the business emanated. So I thought that is very interesting. And so for 2 months, they were doing really well until March, until Italy really is on fire, and everyone was just so shocked at what's happening to Italy. And we were really trying to help with the local leaders on the ground, and really sad and depressed, because we just couldn't figure out exactly what to do. But then, so Hong Kong start to have a little surge here. That's all incoming, and they have a little bit of the community one, and that caused them to shut down, like to shut down some of the beauty salon, and also start restricting people to have just 4 people to go to restaurant, but they never really shut down the restaurant. So I think it looks interesting. This is Singapore, almost identical performance for 2 months until they have exactly the same problem with the incoming. What is the difference? And for the longest time, I couldn't quite figure out what the difference is. Apparently, Hong Kong tests every single individual coming in and monitor every one of them, even the ones that are negative in the testing, with the understanding that even though if the testing is negative, there's no guarantee, because they could be the one with 21 days of incubation. They never have the viral count to be positive. So then Singapore didn't do that. For those that are negative, they just let them go without monitoring them. And I think that's it. Now there's community spread, and especially the domestic workers. And you notice that once you have community spread, then you have to work 100 times harder to control them. So it's really, really difficult, I think. So this is the difference. And the period of the incoming travelers, that's I just marked them. And here's the difference between the two cities. Nonetheless, I think Singapore is still doing well, and they are putting more restrictions, allowing only one person, one household to go out at one time. So then King County, this is the one we work really closely with and fought really hard. And I think they finally closed the, the schools and everything. And you could see they really benefit. You could see the curve is amazing, even though you notice that they really, really are late from our point of view. But nonetheless, I'm happy that they were able to actually see the results. And of course, they are not getting like the best result of the green lines, but nonetheless, this is the best result we could expect. And Atlanta, okay, this is where I live, and I cannot say that we do too well. And we didn't do well because we have community spread, and people are not social distancing. They are social distancing in a group, very large groups. And also lots of business open up, like non-essential business. And so you could see we are heading in an upward trend, not good at all. But I hope that we can do more, because we are still testing. So it's challenging. So what we do see, and I will show you a graph, is that across the United States, 50 states that we look at, so all of them has implemented non-pharmaceutical interventions between day 0 to 4 weeks delay. And it's amazing. We see clear evidence, even the ones that are late. And I think that's great. And that really show that it is worthwhile. It is not true that the disease will be done in 5 weeks. Absolutely not, because some patients stay in the hospital for that long. And it takes a long time to even just deal with a single individual. And we have like 90% of the patients are still in the hospital, which is a huge number of patients. So the interdependency and cascading effect cannot possibly be overemphasized. So everyone that is next to you, the cities next to you. So there's an article in New York Times I really love. I think a few years ago on Newsweek. It say, you are what your friends eat. Now that is about how big or whether you're healthy or not. But this is exactly the same. Your neighbor, whatever your neighbor is doing, the fire in your neighbor state is going to be a fire for you. And so everyone has to coordinate. And so you see the coordination now among some of the governors. I think that's really important. And it is a very fragile, dynamic system that we are looking at. This is totally unlike all the simulation system that we have ever done. It says clearly no steady state. The state is so fragile that any community outbreak, if there's multiple of them, it will just restart everything all over again. So, and I think that is really what we need to understand in terms of the disease itself. And I want to show you the reduction of the potential pharmaceutical intervention, and also how it affects if you do it like fast. So this is like if you do it in right at that moment, the right time, or if you do it like a week later and another week later. Now, this is what I really think the policymakers need to understand is, and some of them are so good, is that they say, wow, it reduced 58% of the infection if I do it now, but if I wait for 1 week, it reduced only 32%. You're talking about totally nonlinear. I mean, it is not like a linear reduction at all. It is a nonlinear reduction, and that truly strike them. And it's really hard to make people listen. And I think those of us in the United States, you also realize we don't really know who the leaders are. So it's like everybody, you have to talk to everybody, and not everybody is going to listen in the same type or same manner. So, and I think that's a real challenge. But nonetheless, I think uniformly we see a huge difference in the reduction of infection. And we also see that, like, if we don't have school closure, and I love the question that was asked by some of these, is it like McKenna or something? I forgot, somebody asked the question, can we do herd immunity? The answer is absolutely not, because you will have to have up to 85% of the individuals to be infected in order to have herd immunity. By then, 20% of these people need to go to the hospital. You have no ability to do that. Even if 1% of the population is infected, that will already overwhelm and collapse our healthcare systems in the United States. And that means in many other countries, except Germany and Switzerland, probably. So, or Iceland. So this is a very interesting graph. And I get this from Carter Mitchell. And it shows three very distinct groups. And they implemented the NPI, and this is the result. 31 states are doing really well, and that represent more than half of the US population. And group 2 are the one that is on the fence. They could go better and they could go worse. And this is about 12 states. And Atlanta is, Georgia is one of them, unfortunately. Like I say, you know, it's like we can't make everybody listen to us. Although it's kind of funny. Some people listen and some don't. And so you see a whole 9 yards of different type of implementation. And in 7 states, this include New York City, New York, New Jersey, and Pennsylvania. All of these are group 3 with very high mortality, and partly because of the late discovery, and also partly because of the implementation itself is also late. And the resource is just absolutely too high in terms of the patient population that has to go into the healthcare. So I have like just 2 more slides and that's it. So I've been working on the trade-offs. I have sent out some of the design issue. The trade-off itself is really to balance the number of infection that may occur, which could be second wave, could be a lot worse, and versus the economic calamity that the pandemic has caused. Now, I love the comments. There is no dollar that you can put to a human life. But if you are President Obama, then he put a human life of $5 to $10 million per person. I like that. That's a lot of money. Okay. No money can buy a life back either, right? So I think if we can actually properly handle the pandemic, I think the economics will come back. If we can't, then, and if we delay it longer, then the economics will just drag on even worse. I think that's really very important. In the absence of any treatment that is definitive, and also medical countermeasures, that means vaccines, we don't have any. So I think social distancing and school closures and telework is very important. So I have designed some of these to prepare for the second wave and how to open up the country. And some of the analysis, I actually did some of the economic analysis, and sorry, of course, no time to really share with it, but then I want to share with you in my analysis, there are 3 sectors that are the top most affected by the pandemic. One is healthcare, one and which is 20% GDP in the United States. One is food industry, and one is education. And I'm very grateful. 10 years ago, education would be truly affected by a pandemic, because we don't have any of these online courses. We have like a huge lacking in terms of underserved population. We don't know how to distribute lunch for those school kids that need the hot meals and everything. But we are much better now. So 10 years on, we are much better. So education part, we can handle it really well. It's the healthcare and food industries, the top 2 that is affected. And of course, service industry is affected too. And somebody asked about travel. I think travel is going to take a challenge, and they have to go back to the days when they are not just circulating air within the aircraft. And you may recall the reason why they're just circulating air within the aircraft is because it reduces the use of fuel. So it's cheaper and for the plane. And now And one has to figure out it's not just cheap that we are thinking of, it is safety that matters a great deal. But on the other hand, when we start thinking about reopening, I'm going to go back to the same thing that we're talking about, testing. So we are still not testing well. So the idea of testing like in Hong Kong and like in South Korea, being able to test 10,000 people per day, we are unable to do that in the United States. And I think that remains a big challenge. And how do we treat? And we still don't have the surge, but I think hospitals are getting smarter. They are able to surge to 7-fold or 8-fold of their existing like healthcare resources. So I think it's extraordinarily remarkable, but the safety for the healthcare providers is something we have to analyze. And I'm working a lot on the treatment outcome prediction and also on the vaccine design part. That's really part of what I have worked on actually with a colleague from Brazil, that we have worked on malaria vaccines and influenza vaccines, yellow fever. And so now we are looking at some of these. So I think the challenge is multiple. I think all of you have really great talents. And like I say, I'm just showing you some of the models I have, and I'm sure all of you have many models. And every one of them should answer a question. So remember the following, like as I tell my students, and you're not my students because you are so much higher level and experts in many different ways, is that everybody could figure out what the problem is. So you could just grab anyone and they could tell you everything that goes wrong. But what we need is solution. It's really solution that could implement it. And I think that makes a huge difference in terms of like the life-saving part. So, and I'm happy to share with you some of the materials and those I can share, and happy to discuss with some of you. And if there's any collaboration, I would love that. And thank you. And I really thank you for all the effort of everyone, and also for inviting me. Thanks.
Well, thank you for I can hear my voice. Thank you for being with us, Eva, and thank you for accepting our invitation and your presentation. It's been great, and we had a lot of positive reaction. In particular, our audience seems to be impressed by your ability to get politicians to listen to you, and they're wondering, how do you do that?
I don't think they listen to me. I guess so. Maybe there's a silver lining there. Okay, I was just a professor really, but I think we wrote a paper on mass dispensing and the challenges and how we implemented REAL-OP in the local jurisdiction and how it really works in the state of Georgia. Amazing. The National Security Council preparedness director and biodefense director in the White House saw it. He saw the paper, he loves the work, and then he summoned me up in the White House and to teach them simulations and optimizations. And these are doctors. So I have to say it's amazing. So I'm sure many of you will have those experience, and it was not something I really understand. And also maybe the difference between me and others is that I am very blunt in how I talk. And so I do not, I guess, I don't know. Yeah, I don't know how to, like, for example, if a politician, I remember the first time they say, oh, Eva, we have to, or they say, okay, Dr. Lee, we have to protect New York City. We have to protect all of the people. I said, no. I said, we can't. I said, I give you 70%. So if I can protect 70%, that is all that I can do at the moment. And to them, it's shocking because nobody would ever say that, right? I mean, it's kind of like they want the star in the sky. I can't get that. So I think it takes time for them to understand that I have to be very honest with them, what can be done and what cannot be done. And I think that's what this community can do. I think none of us are good politicians, I'm sure, or else we won't be professors and programmers. But I think just the whole idea that we are passionate, I think that's important. And I think some of them are passionate. And I never know anything about politics. I can't figure out, like, I cannot figure out who is the Democrat, who is the Republicans. But I will criticize, if they are not right, then we'll criticize, right? And so I think it's fine. And I think that is an important part. But at the end of the day, being able to give them action items, that's important. Sometimes they don't listen, but I don't care, right? I mean, if I say this is what I think truly would happen. And as you see in the news, right? I mean, we provided some of the recommendation back in early February. Nobody cares. So then I'm like a broken record, and I keep saying, no, we have to do this, and I repeat it one more time. And at some point, I think somebody would care, but it is a lot of fight. And so I think we just have to deal with it and continue to do the work that we are good at doing.
Yeah, and no, absolutely. And this is another question that comes from the audience, and I think it's somewhat connected to what we were discussing. So on one side, you have simulation models to convince politicians to draft law, to take measures. On the other side, you have people that actually needs to take these measures seriously. So, and I come from Italy, where the law has been enforced extremely strictly. And but it doesn't seem to be the case in many other countries. So how do you get people actually to follow these measures?
Yeah, I think, we had so many good friends from Italy. In fact, we were talking to the doctors, and it's really tragic to see how little resource at the end of the day, right? If you look at Italy, France, and all of these. And I think citizens need to understand their contribution makes a huge difference. And that's what the one thing that they don't realize. For someone that is infected and perfectly healthy, right? Perfectly healthy infected individual going around, that is the best spreader. And that's why we need everybody to wear face masks, not because they are going to protect themselves from someone, it's that they have to protect someone from themselves also. And I mean, I know there is the incentive, right? The things, and I'm not very good with anything with money. I'm not good at, because it's, if you look at Hong Kong versus Singapore, right? The implementation is really different. And we cannot say, okay, you don't do this, I'm going to charge you for $50,000. They cannot pay, and they're not going to listen. So what can you do? But I think the messaging is extraordinarily important on the ground. And I think that actually does work. I remember when I was in Japan, when I told the people, this is what's going to happen on the radiation stuff if you do not act. And we show them exactly the radiation dust that they touch their face and how the burns actually really happen. And I think once they see that, they realize that. And I think that is the part that we don't seem to be able to do, not us, right? Not our community. It's the mass media. Because if you look at reporters, in the same way as Ebola, and I really appreciate some of you guys were actually also working on Ebola, and I was also working on Ebola with the West African country. So Ebola is a good example. Nobody ever talked about how it was transmitted, because patients actually vomited out with huge amount of stuff that would just spew it all over, right? Now, COVID-19 is totally different. If you tell people 70% of the environment is basically contaminated, and 17 days, after 17 days in the Diamond Princess, the surface is still infectious. If citizen learns that, I think they will act. And I think you are absolutely right. I think people like in Europe learn the hard lesson now. Brazil is facing it. And my colleagues from Brazil is telling me they are struggling because policymakers are not taking the steps. So it seems like we keep learning or repeating the same mistake over and over again, and we shouldn't. Because, when it gets to Africa, when it gets to, Latin America, we are facing another hurdle and to the epic proportion. So we better do well. I mean, and I totally sympathize with everyone, because we did the same thing here in Georgia. And it's really difficult, because when people are so healthy, they don't realize what could happen. To give you an idea, my colleague treating a 25-year-old patient, he was perfectly fine. 2 minutes later, he died of rapid heart attack. And the providers were traumatized. So, and they told me, they said, Eva, you cannot believe what we saw, and we cannot function like this anymore. And I totally agree. And that is the type of message we need the public to know, because if public does not know, they think they are so healthy and they are immune from it, and they just want to protest, and that shouldn't even happen.
Yeah, and I'm sure that the Nth guys, which I'm seeing that I'm getting ready for the next talk, they will have a lot of stories to share. But first, I want to ask you one last question that was coming from the community, just to switch topic a little bit, and the $1 million question. So, when do you believe that this epidemic will be over? By this summer, or?
I was asked many times,
I
and
guess.
I wish I couldn't predict things, right? Then nobody would ask me. But then now it's really frightening, because then when I start predicting, then it happens, and then I thought maybe that's a curse. So unfortunately, I think it's going to take us at least 2 years to, like, if we are lucky, is that we will not have second wave. And I think Europe is being tested first before United States, and maybe United States cannot wait to be tested right away, right? Because our leaders want to open up, but Europe is going to face a very key issues of opening up, and the connectivity is so densely related to each other, right? Everybody, like all the transportation and stuff. So if we are lucky, we got the vaccine, and everybody will be protected exactly just like annual flu, and that we have enough for everybody, that we get enough herd immunity across, because we will never have enough vaccine for everybody. And then we are really in good shape, I think 18 months and in 2 years, and we get back to totally normal. That means we can travel, everybody is happy, and we will have sporadic, just like influenza. If we don't do well and we have a second wave, I fear that we really are facing just like Spanish flu. The second wave is a lot more deadly. Part of the reason is I am a little surprised at how fast the virus have already mutated, even in China. So I actually work a lot on genomic stuff, and because of the work I do on gene and immunity prediction and on the vaccine design, I was really surprised how fast the vaccine, the virus has mutated, and that probably explain why so many people died. And because if you look at it, the virus is attacking people in many different levels, not like any other virus before. And so basically it attacks healthy people, basically the heart, rapidly. It attacks all the people with existing condition, all of those conditions, and patients die with multiple organs failure. And it's not because they cannot breathe. And even those patients with ventilators, and I know that, like, I know Italy didn't have enough ventilators, and they felt like patients perished because they don't have ventilators. But we have 65 to 80% of the patients on ventilators perish because of organs failure. So it is not the Italians that miss those. Of course, they could have saved more, but look, the system is totally overwhelmed anyway. So I think, I don't know what will happen. I fear that if we open up too early, then yes, we'll have second wave, and this time we'll have a lot more people in the hospitals, and we will not be able to handle. Because the odd thing about the timing, did you see what is happening? The timing is a lot closer now, right? In China, the timing from China to Italy, we have it all to the perfection. And the timing from Italy to United States, we know exactly how many days we are behind Italy. So we are 6 to 8 weeks behind China, right? We have 4 to 5 weeks. But do you see what happens now? We're not even done yet in the US. It's all over in other continents. And so the timing is getting shorter and shorter. And if there's a second wave, the second wave is going to overlap with the first wave of some of these people. Then the whole world is in crisis, right? And then I don't see who can help us if we cannot help ourselves. And citizens at that time, if they want to lock themselves up, that will be too late, right? So I hope that they get that's the message and truly do their part, because by doing their part, they are helping the government. And I think that that's really very important, and helping themselves too, because at the end of the day, one of the relatives is going to die, because we are all connected, right? 6 degrees of separation. We know so many people, and I have colleagues in Italy, I have colleagues in Brazil, and every one of them is in distress, and I think we have to work together. That's very important.
Thank you so much, Eva. Thank you for the optimistic words at the end. And I think I'm gonna pass on the word to Ben for our next talk. It's been great to have you, and hope you're gonna stick around for the next talks.
Sure. Thank you.
Yeah, thanks so much, Eva, for that talk. There's just such a wealth of experience and knowledge here, which is certainly a huge contrast to what we read about COVID-19 in most of the mass media.